Hello, I'm James Fotheringham, an academic nephrologist at the University of Sheffield and the Sheffield Kidney Institute. I've performed a number of economic evaluations in renal replacement therapy, and I was delighted to be invited by KDIGO to give this presentation to you today, How Economics Can Drive Home Dialysis Use. These are my disclosures, which include lecture fees and research grants from industry, in addition to formal research funding from other bodies in the UK. This is an overview of my presentation today. I'm going to explain to you the principles of health economics, including its core goals, the informing data and techniques it uses to achieve these, and the perspective through which these analyses have been undertaken. I'm then going to explain what health economics thinks about home dialysis, and then what policymakers, clinicians, and patients think and also behave in response to the economics of home dialysis. First of all, I'm going to explain to you what economics is. So economics concerns itself with how society allocates resources amongst its alternative uses. And when considering health economics specifically, I'm going to focus on these three domains. First of all, what is health and how do we put a value on it? So when we consider what health is, we're really asking individuals what they consider to be good or bad health. And then in other scenarios, we're also asking them to put a value on it, specifically thinking about cost. Now, as both of these things mean different things to different individuals, it's quite a heterogeneous topic and could be the subject of a presentation in its own right. So I'm not going to talk about it in too much detail today. What I can talk about is what influences supply and demand. So thinking about supply briefly, this could be considered the economic considerations of supplying enough nurses to train patients to do home dialysis. Demand, on the other hand, could be considered as what are the costs associated with home dialysis treatments and how that influences whether or not an individual would choose that particular modality. Finally, I'm going to talk about economic evaluation. Now this comes in three different forms. Cost minimization is when we recognize that different treatments could be associated with different costs and we choose one that minimizes the total cost of the healthcare service. Cost effectiveness, on the other hand, is where we accept that better healthcare costs more, and we aim to calculate the additional cost associated with preventing an event, like saving a life or preventing a heart attack. Finally, cost utility analysis is where, again, we recognize that better healthcare costs more money, but the unit at which we assess that improvement is the quality adjusted life year. And it's this form of analysis I'm going to go into more detail. I'm now going to use cost utility analysis to demonstrate how health economics evaluates home dialysis, using this well-regarded Danish study informed by a systematic review. Health economic evaluation also often uses a model-based structure where patients move through various states. Here we have patients starting with severe renal failure or end-stage renal failure, and then they begin their renal replacement therapy journey either on peritoneal dialysis or hemodialysis, here stratified into 4 different types. Now, as you would expect, patients can move between these 2 dialysis modalities, but can also be subsequently transplanted and die. Now, as patients move through these models, and these various different states, they accrue costs. This table outlines the various different cost domains that this study used per annum, which were assigned to patients while they were in these different states. Now, patients do not spend their entire time in these models in one particular state, such as peritoneal dialysis, and it makes clinical sense that patients move between these states as time goes by. These are informed by probabilities, and here in this study they used a systematic review to obtain the probabilities per year of moving between peritoneal dialysis, hemodialysis, transplantation and death. You can see here that the review identified a range of probabilities of moving from PD to HD of between 5 and 14%. In addition, while patients are in these various different states, they accrue quality of life. Now, these are referred to as utilities, A utility is a way of measuring quality of life where 0 equates to being dead and 1 equates to being in perfect health. You can see that while you're either on hemodialysis or peritoneal dialysis, annually a patient was at about half the quality of life expected of being perfect health, with further decrements when patients developed infection, had a myocardial infarction, or suffered sepsis. So we have a model that over a 5-year horizon captures the time that patients spend in each of these states or dialysis modalities, the cost that they accrue while they're there, and also their quality of life. What does this tell us? Well, we can see here that peritoneal dialysis over 5 years accrues approximately 1.68 quality adjusted life years at a cost of around €165,000. Whereas home hemodialysis accrues slightly more QALYs, 1.68 QALYs, at a cost of €228,000, so costing more. Now, when we compare these, we can see that there's more QALYs associated with home dialysis, 0.18, however, an additional cost of €63,000, meaning the cost per quality adjusted life year comes out at around €356,000, in excess of what most people would consider cost effective. Meanwhile, the home dialysis strategies like hospital, self-care and satellite have smaller quality adjusted life year gains of around 0.035, but at an even greater cost, meaning that they are wholly non-cost effective in comparison to peritoneal dialysis. Is the conclusion about the health economic advantages of home therapies likely to be the case across all geographies? This figure is adapted from an excellent paper by Karapady, where we order country by GDP from high on the left to low on the right, and we plot the ratio of hemodialysis cost to peritoneal dialysis cost, where being above the line means that PD costs less than HD and below the line means that PD costs more than HD. What does it show? It shows that as GDP drops, broadly speaking, the cost of hemodialysis drops, probably due to reduced staffing costs. And that would mean that potentially the health economics of hemodialysis would look preferable to peritoneal dialysis. Each one of these dots is a study, and it's important to consider each individual study and what they used to determine the costs. For instance, we know that hemodialysis costs are often derived from the tariff or the reimbursement cost per session, whereas peritoneal dialysis costs are often estimated from a grounding up exercise. As a result, this can introduce some bias. Nevertheless, what we can see here is that as hemodialysis costs more than peritoneal dialysis, there's an increase in the number of patients receiving home therapies, in this case PD, in the country. i.e., if PD costs less than hemodialysis, you're more likely to have patients on it. Sticking with countries for the moment, this recent study performed by the ERA-DTA registry performed a questionnaire across European countries to determine their attitudes towards dialysis modality. What we can see here is that irrespective of GDP, respondents felt that there should be more home hemodialysis and more peritoneal dialysis relative to in-centre hemodialysis. However, despite uniformly feeling that there should be more home therapies, people from low GDP countries felt more positively towards in-centre hemodialysis and relatively negatively towards home hemodialysis. Meanwhile, peritoneal dialysis attitudes were the same according to GDP. So what's driving these differences? Well, I've already alluded to the fact that staff costs vary according to GDP and may be driving the difference in attitudes. Also, PD fluid costs, which are a large determinant of the costs of PD, vary by country. This may be down to the location of manufacture or the ability to manufacture these fluids within your own country. You'll see here this figure from the Karapady paper that shows that if you've got no local manufacturing or high import duty, hemodialysis will seem cheaper than peritoneal dialysis. Whereas if you've got lower manufacturing or low duty, PD will seem cheaper than hemodialysis. Sticking with what clinicians think, this questionnaire study from the ERA-DTA also showed that in countries without access to home hemodialysis, the majority felt that financial barriers were the reasons that they weren't able to access this particular modality. Meanwhile, in countries that did have access to home hemodialysis, 80% of the time, respondents felt that the costs to the patient and hospital reimbursement were not barriers to accessing these therapies. The Explore Home Dialysis Programme looked to evaluate its immersive educational programme and polled the 11 countries that participated, all of which said that financial barriers existed in the deployment of home dialysis around the world. What's interesting is that when you look to the description of these financial barriers, they explain that home dialysis patients require a personal dialysis machine, constant supply of clean water, energy and various machine consumables. Because the practice of home dialysis is new in many countries, many of the funding, care models and reimbursement models do not enable support of home therapies of this nature. As a result, many patients cannot currently afford the costs associated with setting up, running and maintaining dialysis equipment in their homes. One conclusion from this might be that there needs to be robust remuneration mechanisms for both the providers and the patients when deploying home dialysis. So, we've just alluded to remuneration mechanisms, which are largely informed by policy. So what do policymakers think about the economics of home therapies? Remuneration mechanisms vary across the world and were nicely summarised by this paper. They go into 4 categories. Global budgets, where there's a fixed amount of funding for a dialysis facility. Fee for service, which is where you get a payment for each of the individual services or modalities that you offer. A pay-for-performance model, where payments are based on meeting certain targets in care, quality or safety, or activity-based funding, which is based on the number of patients or the number of dialysis sessions you deliver. What's important is there's evidence that movement between these mechanisms has been associated with changes in home dialysis use. Before we dive into what can be learned from these various different changes in reimbursement models, I think it's important to say that the quantitative policy data that was used to analyse these was largely from before and after studies, i.e. not with randomisation. It's widely perceived that physician payment models influence practice, but this has not been formally quantified. Their statements are rarely qualified by evidence and generally assessed through questionnaire-based studies. So first of all, let's start with Canada. The move from a global to activity-based funding formula with associated more generous estimates of costs for home dialysis resulted in an increase in the use of home therapies between 2011 and 2016 from around 21.9% to 26.1%, an increase of 4.2%. The country that's seen the greatest changes in the reimbursement mechanisms in recent history is the US. In 2004, they moved to a tiered fee-for-service system, which included extra capitation or payments associated with seeing hemodialysis patients weekly. Around that time, there was an absolute decrease in the number of patients receiving peritoneal dialysis from around 7% to 6%, which was observed in the larger facilities but not in the smaller ones. In 2011, they moved to an activity-based funding mechanism, which included bundled payments which included erythropoietin. This meant that hemodialysis patients who received more erythropoietin relative to peritoneal dialysis patients cost the provider more. In addition, there was a more generous remuneration for home training. As a result of this, there was an increase in patients receiving peritoneal dialysis in the first 90 days from 6.4% to 8.9%, and receiving peritoneal dialysis from day 60 onwards from 8.9% to 12.6%. Understanding what drove these changes, we can see that this was as a result both in an improvement in the rates of switching from PD to HD, there was a reduction observed there, but also an increase in late switches from hemodialysis to peritoneal dialysis. As I've already explained, many of these analyses are informed by before and after data. However, there is some randomised data on the horizon. Many will be aware of the ESRD treatment choices model, which is a combination of changes in payment, fee for service and activity which involve an upward adjustment in nephrologist reimbursement and a downward payment adjustment based on the proportion of patients receiving home dialysis. As I understand it, individual providers will be randomized into this, and it will be really important to see how these changes influence home therapy uptake. Finally, I'll spend what probably isn't enough time talking about what patients think about the economics of home therapies. Rachel Walker performed a discrete choice experiment in 143 patients who were expecting to require renal replacement therapy in the next 12 months. Now, a discrete choice experiment is a questionnaire-based study where you give the respondent a scenario with some options which they have to choose. In this scenario, home hemodialysis, peritoneal dialysis, and in-center hemodialysis were offered. With these offerings, there is a range of benefits, harms, and costs which vary with each question, and there's normally around 12 questions. With these benefits, harms, and costs varying with each question, you can build up a model which assesses the comparative effects of each of these domains on the odds of the patient choosing a home dialysis treatment. Here we see that with each extra New Zealand dollar of out-of-pocket cost per month, there's around a 2% reduction in the odds of the patient choosing home dialysis. Home hemodialysis patients in New Zealand are remunerated approximately $40 per month for consumables. This means that if this remuneration did not exist, the odds of the patient selecting a home dialysis would be around half the odds of them selecting it if they were getting that payment. The other advantage of a discrete choice experiment is it allows you to perform trade-offs between the various different attributes. Here we can see that patients would be willing to spend between 200 and 400 New Zealand dollars on unlimited nursing support and increased flexibility. So what are the out-of-pocket costs for the patient? I think it's first of all important to say that clinicians believe that out-of-pocket expenses are a barrier to them recommending home dialysis. So first of all, there are things like equipment, consumables, and electricity. Patients report extended time away from work for the training as a problem. There's also housing problems. So the space to store the peritoneal dialysis fluid and to problems maintaining the water quality for home hemodialysis, and also more generally the suitability of the environment. And these factors all add up to patients with a socioeconomic disadvantage, so here represented in red as the most deprived, having the lowest probability of home hemodialysis and peritoneal dialysis, and the highest probability of receiving in-center hemodialysis in this UK data. So, in summary, there are health economic advantages to home hemodialysis. However, they're unlikely to be consistently the case across geographies and will be influenced by changes in cost, utilities, that's the quality of life of the patients receiving a treatment, and the competing events over time, such as transplantation and death in these individuals. These are influenced by patient, system, and geographical factors. Qualitative and quantitative evidence from the literature suggests that the economics of home hemodialysis therapies influence their use, and there's some evidence of policy and practice interventions, specifically around reimbursement models. However, more formal evaluation of policy change and more innovative assessments of health, costs, and what constitutes value could drive further changes in the uptake of home therapies. Thank you.